Thank you. Good afternoon. Sorry, excuse the absurd title. I just thought I wanted something fun, if it makes any sense. So when to take vinegar in this case, we're talking about acid or acetic acid, with a pinch of salt. So when acid-fast bacilli don't necessarily mean TB, and we don't always have to take, when we shouldn't take the results seriously. But quite put simply, it was an approach to a differential diagnosis for a specimen that is AFB positive. Like Jeremy said, this comes up quite often, certainly in peds. Sorry, I'm just trying to, okay. So just to cover again for anyone who doesn't recall all the details, what does acid fast actually mean, and what stains positive as acid fast? Acid fastness is a physical property of an organism because of its waxy cell wall that makes it hold on to its color in the face of being exposed to an acid alcohol. So it resists decolorization by acids during the staining process. So it holds on fast to that to its color. And yeah, like I say, it's because of the certain bacteria which have this waxy cell layer in their wall. And then it allows identification using, I'm saying simple in inverted commas, microscopy, because I don't actually think the whole process is that easy to just look under a microscope and see it. I think you do need some skill and experience. It is quite sensitive and specific, but really it's all to do with the clinical correlation together with your findings. And we generally use it when we're suspecting mycobacterial, particularly TB infection, or rarely a nocardia infection. And the reason it's used for TB so much in mycobacteria is that they don't stain reliably or consistency with a gram stain, which we would use on many other organisms. So although nucleic acid amplification tests, what we were calling up until recently just simply gene expert or PCR, well, that's what we used to be ticking on our forms, just brought that in, although that wasn't really what we're discussing here. But I think we often wonder, are we supposed to tick the nucleic acid test or ask for acid-fast bacilli, which usually we just tick TB microscopy. So what is the difference? The good thing about the microscopy, which is referring to the acid-fast stain, is that it's available more likely than having a fancy PCR machine in low resource settings. And it's actually a good diagnostic and screening tool for active TB. So it's also the only thing really that you could use, versus the PCR test to monitor the response to treatment, because if they were AFB positive at the start of treatment, 2 months later, if you check them again, the PCR test may be falsely positive because there's still DNA around. But if it's negative, the patient has responded to treatment. And also the load, it'll tell you whether this patient is infectious or not. And that's important because the patients are out in the community. The cons are obviously there are false positives, there are false negatives. And I put in as a relative con or disadvantage is that it does require proper training and expertise. It's not just something I'm sure you can set up in the middle of anywhere and stain it and have a look and diagnose with certainty. Whereas the nucleic acid amplification tests, the pros are that it's very sensitive and it can also differentiate species or groups and also provide sensitivity results as well, which obviously the microscopy can't do. And the cons are that it's so sensitive and it can lead to false positives, and it can't be used to determine the response to treatment. So ideally, we would ask for the stain and the gene expert in most situations, in the nucleic acid test in most situations when we send a sample. So just some other things that do stain acid fast. So under bacteria, there's the mycobacteria, as well as the actinomycetes, which I personally always get confused with actinomyces, which is actually not acid fast. So actinomycetes is the big group, and not all of them, but those in that group with mycolic acid in the wall, particularly specifically nocardia, I think is the clinically relevant one. Some parasites, Sarcocystis, Cryptosporidium, Cystazosprobelli, I think it's now called, so that's Cystazosprobelli, That's our cryptosporidium staining nice and red against the blue background. Tinea saginata eggs, hydatid cysts, and then some things that aren't even infectious, nuclear inclusion bodies in lead poisoning, and the head of spermatozoa. And there at the bottom is a nice picture of the branching filamentous nocardia. So how the test is actually done in the lab, it's not only about the staining, actually the smear technique is very important. How thick, how thin to spread it. And the sample specimen itself is you can't just use any specimen. It has to be quite specific, which I'll get to. So just in case you, like me, have heard of all these names and get a bit confused as to which is which, there's the two types. There's the Zeal-Nielsen and variations of that, Kenyan and modified Kenyan staining, and then there's the fluorochrome stain, which is this top one, which is fluorescent. And basically these three, the Zeal-Nielsen, Kenyan, and modified, use carbylfuchsin, and I don't know if some people say carbylfuchsin, and then fluorochrome uses auramine O or rhodamine, and I think you might have seen that on some of the laboratory reports. You'll usually see TBZN, or you sometimes see, well, I've seen auramine O as well. So I just compared them. So Zeal-Nielsen was invented or discovered by two different physicians, and then used also by Koch for TB diagnosis. And basically your staining agent, the thing that shows up nice and bright and red, is the carbylfuchsin. Then you have to heat it over a flame so that it steams a bit. You mustn't heat too much, you mustn't heat too little. Then you decolorize it with a 3% hydrochloric acid, rinse that off, and then put on the counter stain, which is methylene blue, and rinse that off, so that essentially whatever is acid fast, even in the face of this acid, will hold on to the red coloring. And then you rinse the rest off and put the methylene blue on, and that will show up the background. So you should see red against blue, and that's used typically for mycobacteria. And a few of the other things I mentioned, the parasites possibly. And then the Kenyan stain, the difference here is I must be missing something. I'm not quite sure why this guy got something named after him, because essentially it just seems like a bit of a lazier method. He realized you didn't need to use heat. So with this method, they don't use heat, and so it also seems to be a bit quicker, but then you do need more carbylfuchsin. I think some lab people might be able to correct me on this. I mean, but when I spent some time in the lab, I saw that reagents often run out. So maybe when you need to use more of one thing, it actually does affect your, you can't do the tests. And it seems that what I read, that Kenyan is actually quite obsolete now. So ZN is usually done. However, modified Kenyan is done when we are looking for something like nocardia and cryptosporidium, because they don't hold on to that stain as strongly as the mycobacteria in the face of a strong acid. So you use a weaker acid, and in that case, then they will show up after you decolorize with a weak acid, put on your methylene blue, and then that can show up. So you can use it for specific organisms. Okay, so then the auramine, our fluorescent stain, it uses auramine O or rhodamine. No heat is needed. Also decolorize with an acid, hence acid fast. It's still an acid fast test. And then the counter stain is potassium permanganate. And, oh, please forgive me, it's not KPO4. It's I was just taking a shortcut. That's potassium phosphate. It's potassium permanganate. Rinse it off and then look under the microscope, and it fluoresces. And apparently this is more sensitive and specific, and also because these organisms tend to shine up nice and bright, it takes less time in the lab. So it is a faster test. And then if you've heard of any other stains, I don't know if I've heard of this, but I was reading about it, the FIGHT, I'm not sure if I'm saying it right, and obviously immunohistochemistry, that is what's used in histology specimens, and it can also stain nocardia. So if we were to just look at the Zeal-Nielsen stain, you have your slide prepared, apply the primary stain of the carbylfuchsin for a certain amount of time, heat, will then fix the cells to the slide using the flame, decolorize with your acid, the hydrochloric acid, for 15 to 20 seconds, so it washes it. You won't and should take away make all the other organisms invisible, really, and then you apply the counter stain of methylene blue, and your acid-fast organisms show up, and they've held onto that red colorant. Maybe it is fuchsia. How do acid-fast bacilli actually look, for those of us who don't know or haven't seen it? They are slightly bent, beaded rods that are 2 to 4 microns long, and they vary in width depending on the species. And apparently when they are seen in sputum, they lie parallel to one another, or meeting at one end looking like a V. But morphology can't always distinguish which mycobacteria they are being seen, but they can differ in length, width, and arrangement. So I'm sure to the experienced eye, they can have a look and know immediately what they're probably looking at. M. cansacii is long and broad. The M. avium complex is coccobacillary when it's grown in a liquid medium, which I believe we seem to use more because it's quicker than the solid, the Lowenstein-Jensen. And Mycobacterium tuberculosis group, this I did hear about in when I spent some time in the lab. They appear in cords, which are long strands, which I'm trying to show here, where the bacilli are actually lying parallel to one another, and then appear in these cords, also when grown in a liquid medium. But this can only suggest a certain species or group. It's not definitive. You're not going to put out a report based just on that. So I just threw in things that we have to bear in mind, that for anything to even show as positive in the sputum, you need approximately 10,000 organisms per mil of sputum for smear positivity, which always confused me. So you need that much available so that you might even just see 1 or 2 of those on your slide. The detection of more than 10 per slide is optimal, but apparently seeing even 1 is suggestive, but you probably would want to see a few more to make a definite diagnosis. And compared to culture, AFB smear sensitivity in sputum is about only 60% that of culture. And obviously, as you know, it's lower in non-cavitatory disease, which is what we usually see in kids. So we have a very low positivity rate, and also in HIV positive patients. It does have a 10% increase sensitivity when you send a second specimen, and after a third, just a small increase by another 2% of yielding a result, a positive result. And it does help to process the specimens first with bleach. I think that's to get rid of other contaminants. And also, if you increase your concentration, you can increase your yield, and that's usually by centrifuging the specimen. So at the bottom, I've just... this is a WHO guideline for how to report positive AFBs per field seen under the microscope. CDC has a vaguely different one, but they do say different countries, some have adapted to what they count as positive. They use slightly different reporting guidelines, but essentially, obviously, if they don't see any AFB in 100 fields, that's negative. 1 to 9 per 100 fields, then you say how many you saw, and then thereafter, 10 to 99 is positive. If you've got actually 1 to 10 per field, it's very positive, and goes on. Okay, so what else other than the things I've just mentioned can affect the sensitivity and the specificity of the test? Again, from time spent in micro, they seem to answer things nice and systematically, dividing into pre-analytical, analytical, and post-analytical factors. And I think we all know that this happens all too often, that we send off a specimen and it's incorrectly labeled. So I suppose that can give you a false answer because this patient does have TB, only you sent it under someone else's name or got the things mixed up. So incorrect labeling, incorrect storage and transport, because it must be transported between a certain temperature. And I think we also know that if we're getting specimens in from peripheral hospitals and clinics where it's very hot and it takes days to maybe get to a more central lab, that can affect the yield. And also if it's been poorly collected sputum, sunlight and heat can also destroy the bacilli. Then analytical, because it's a carefully measured out process, if the smear is done incorrectly, that can affect the yield. if the stain is left on too long or for too short, if there's contamination of the slide, a problem with the heating, and if it's blotted dry with paper, that can also affect it. And then obviously microscope issues. If there's like a mark on the lens or something, I suppose that could. And I do recall once as a reg, we just kept getting positive AFB results till we thought this is very bizarre. This shouldn't really happen. And I think there was a problem in the lab. And so we have to question when we get an unusual amount of positives. And also observer variability. So training is crucial to remain consistent and accurate. And then post-analytical, if you mismatch the patients and their results, incorrect reporting, apparently it must be written as 3+, not +3. Delay in turnaround time, I suppose that shouldn't really affect sensitivity or specificity, but if patient waits too long, then they presume or something that they're negative, and actually they were positive because they've been waiting so long for results. And then I think this is placed on clinicians a lot, the incorrect result interpretation, where they don't really have TB, but we've seen positive AFBs. And so now we say they have TB, and we haven't thought of all the other possibilities. So why would we get false results? So I was thinking false positive AFB in a patient who doesn't have TB is either when it is just read as positive, or there is an AFB there, but the patient doesn't have TB, tuberculosis. And the problem with that, which happens quite often, is that there's serious consequences. Well, potentially, if we go and tell a patient they need to take potentially toxic drugs for not a short time with drug interactions, because a lot of times the patients are also on antiretrovirals. And then I would imagine there's also a stigma. Obviously, there shouldn't be, but if someone tells their employer they have TB, you don't know. So to give someone this disease they don't have, it can be problematic. And obviously, you also know that toxic side effects can be hepatitis, peripheral neuropathy, optic neuritis, and things like that. So we don't want to treat someone incorrectly. And how would this happen? The false positives, there might be old slides. Perhaps there's still marks on the slides. Cross-contamination when you're processing a lot of samples. Maybe the bacilli move from one to the other slide. And also transfer of AFB on that oil immersion lens. Also, if there were food particles in the specimen, and then precipitation of stains. So sometimes if it's unevenly distributed, it might actually look like an organism that's not really there. And then sometimes when you see AFB and they are there, but they're not actually TB, which you'll probably find out later, but they're actually environmental contaminants, whether that's causing disease or incidental, it could be either. And then false negatives in a patient who does have TB, this could be from any faults during the processing and just not detecting what's actually there, or the patient has TB, but it's actually not present in the sputum because it's actually porcine bacillary. So what samples can be examined? Essentially, if you can get a biologic fluid or material, you can ask for AFB on it. Most commonly, I would imagine we send pleural fluid, CSF, urine, and us NPs, we send gastric lavage a lot, and I'm sure it's also done in adults sometimes if they can't cough. Thin fluids are best, and then it's looked at after centrifugation. But because TB is most commonly a pulmonary disease, we're going to usually start by getting respiratory samples, assuming the patient has a cough, and even if they don't, we try and induce sputum. So cough is the most common mechanism of getting some sputum out of certainly adults and maybe older kids. Just to remember that if you're a healthcare worker aiding a patient in giving you sputum, don't forget to wear PPE to protect yourself. And you really have to try and explain to the patient that you don't want the saliva in the mouth, you want it to come up from their lungs. Induced sputum, that's if they need a little bit of help, maybe to make the cough a little bit more productive. So warm hypertonic saline, 3 to 5% is used. It does apparently look thinner. And so you should label it induced sputum because it might be discarded as being an inappropriate specimen. Bronchoscopy obviously is invasive and it's not available everywhere. And this should only be used as a second or third line technique for diagnosis. It's certainly obviously not a substitute for any other ways of getting sputum. But certainly in diagnostic dilemmas, when you're not quite sure and the patient might be very ill or in ICU, something like that, it's an option. And with that, you can do bronchial washings, brushings, or a biopsy. And then gastric washing or aspiration is what we do mostly in peds, and also I would imagine in incapacitated adult patients who can't cough. And the idea there is to obtain the sputum that was coughed but not expectorated and swallowed. And we all know the first specimen of the day is the best, but we often actually, it probably still is, but when we've got kids who are feeding 3 to 4 hourly, depending on their age, I don't think we always have to wait for the morning. We can just wait before the next feed to make sure. But I think the routine is often in the morning, so we're lucky if we get one later in the day. So there are sputum collection guides. So they should, I like that, with filtered water. In the morning, you must rinse your mouth with filtered water. And then they say breathe in and out a few times and then cough and put it in this bottle, plastic specimen bottle. So purulent and mucopurulent sputum are good specimens for microscopy. Suboptimal are things that look more mucoid, mucosalivary, and just salivary specimens. Blood tinged or blood stained sputum is considered still acceptable. The lab does reserve the right, I think, to reject the specimen certainly if it's leaked, and also if it looks like it's an inappropriate specimen. So labeling is very important if you think there might be a problem. Apparently, at least 5 mils is ideal. We don't usually get that in peds, but it is ideal, and it must be in a clear container so it can be assessed by the people in the lab who are looking at it. It should be transported at 2 to 8 degrees Celsius, and they can be collected between 8 and 24 hours apart, with that first specimen usually being in the morning. But you could send more than one in a day with a space. And so the WHO says, although 3 is ideal, 2 specimens on the same day are a possibility, and I think that, or acceptable. And I think this is very important because of the fact that it's often happening in an outpatient setting. So you certainly can't afford to keep a patient just for that if they aren't that sick, and also transport issues and things like that. So to try and collect 2 on the same day should be possible. So the relevance in our practice, I think, is that we usually request it because we're looking for TB. That's most of the time, unless we are being clever and a patient we think has nocardia or something else, then we ask for that stain. But usually we're sending and ticking that when we're looking for TB. And that's usually the patients who have the typical features, weight loss, night sweats, cough. In kids, it's usually any child who has severe acute malnutrition without any obvious cause is going to have a workup for TB. So there's the weight loss, even if they don't have a cough. Immunocompromised, there's often a background of immunocompromise. Sometimes it's because of lymphadenopathy. But these symptoms aren't specific for TB. So you're often sending it on patients who don't necessarily have TB. And so we just tick the boxes, and we often send specimens, but then the interpretation of results becomes tricky. And the results aren't always specific for TB. So I've already kind of said about what are the acid-fast bacilli. I've mentioned other things that are acid-fast, but when we talk about AFBs, it's really mycobacteria and then on occasion nocardia. But I think usually the lab won't mistake the two because nocardia is branching and filamentous. So the mycobacteria, I also did gain a little bit from doing this to break this down into the groups that mean more to me. Well, that makes some sense. So we'll often see on the results MTB complex detected or not detected, and that is referring to mycobacteria that cause tuberculosis in human and other animals. The ones we obviously know about mostly are MTB and then Mycobacterium bovis. And then there's quite a lot of others, and they don't all infect humans. Yeah. So then another one is Mycobacterium leprae, which seems to stand on its own, and then the non-tuberculous mycobacteria, which we might also have heard of as being mycobacteria other than TB. Might have heard of them being called atypical mycobacteria or environmental mycobacteria. Some cause disease, but many are non-pathogenic, and many are only pathogenic in immunocompromised patients. So not NTMs, they are kind of ubiquitous in soil, dust, and water, and they also can create a biofilm and make them quite difficult to remove, so they live happily in biofilms. And they're generally opportunistic, so they cause disease in people with either with lung disease or who are immunocompromised. And they don't usually actually spread from person to person, except apparently it's been described in cystic fibrosis patients who can spread a Mycobacterium abscessus between other patients. And they usually involve the lungs, but they can also cause soft tissue and skin disease, lymph nodes, especially in children, blood infections, device-associated infections, and bone and joint infections. Again, the symptoms are vague and quite non-specific. Fever, weight loss, night sweats, appetite, decreased appetite, and loss of energy. So this, I thought, was very nicely set out. There's the MTB complex, M. lepri, and then all the others are known as the non-tuberculous mycobacteria, which, from a lab point of view, there's the rapidly growing and the slowly growing. The marinum and ulcerans are, with our TB and lepre, are true pathogens, implying that whether you're immunocompromised or immunocompetent, these can cause disease. Then the ones in blue, so MAC, sure we've all heard of, Kansasii, they are opportunistic pathogens, so they take advantage of an immunocompromised host or someone with lung disease. And then the ones in yellow tend to just be environmental and are most likely contaminants and mean very little on a specimen. So just some manifestations of the NTM. So this is Mycobacterium marinum, which usually apparently infects fish. But if you have open skin and you put your hand in infected water, then you get this along a lymphatic, these nodules and skin infections. Then I was wondering why I didn't see scrofulation, because I've heard of scrofula, and that's kind of the one that causes lymphadenitis. And they say that sometimes is actually clustered with the MAC organisms. So that would be an underlying lymph node abscess, which can break through and cause a fistula, sinus. And then this is M. ulcerans, causing what is apparently also known as Burundi ulcer, and it's quite a problem in endemic areas and still in immunocompetent individuals. So I wanted to talk a little bit about MAC. I don't know how it is in adults, but in peds, this would be the one that we talk about the most, and especially obviously in our immunocompromised patients. We had a patient with this earlier recently, and he had disseminated MAC, and he had a horrible ending. So this we have seen. It's the most common of all the NTMs in humans, especially causing pulmonary infections. So it's a group of genetically diverse strains with different reservoirs and different pathogenicity. And it includes Mycobacterium avium, intracellulare, and those aren't microbiologically separated. So they usually just refer to it as Mycobacterium avium intracellulare, and then Mycobacterium camara. And there's usually two pictures. One of the two pictures of disease, you'll see either pulmonary disease in an otherwise immunocompetent individual who has underlying chronic lung disease like cystic fibrosis or COPD or bronchiectasis, and then extrapulmonary disease. And that's when we see disseminated disease with advanced immunosuppression, and then cervical lymphadenitis, which is relatively more common in children, especially under the age of 3, and usually even if they're immunocompetent. So the incidence of MAC is increasing, but it may not be a real increase. It might just be because of an increased awareness and better diagnostic techniques. It did increase enormously with the HIV pandemic, but then decreased again due to ART. It's a problematic disease. It's difficult to diagnose. It's difficult to treat. It requires prolonged treatment. It seems no one's quite sure how long for how long they need to be treated. And it only has modest success rates, and untreated, it has survival time of about, I think I read 130 days. And disseminated MAC usually occurs in patients with CD4 less than 50. And in one study, they talked about a median of 13, a count of 13, actually. So with really low CD4 counts. And the symptoms, unfortunately, aren't easily distinguishable from advanced HIV. So again, could be night sweats, fever, weight loss. Sometimes there's marrow involvement, so they can have anemia with leukopenia. Often a lot of abdominal symptoms, pain and diarrhea, intra-abdominal lymphadenopathy, and then ascites as well, hepatosplenomegaly, and certainly not always sensitive or specific, but an elevated alkaline phosphatase as well. But if it's difficult to diagnose, you can't just go and treat someone for it, because and it's also quite difficult to know whether it's just the HIV. But interestingly, I think in these patients who have the disseminated form, actually less than 10% have pulmonary involvement. So the diagnosis of MAC, the problem is that AFB sputum smears are not sensitive or specific for the diagnosis of pulmonary MAC disease. And when you get a positive, it could be an environmental contaminant or just colonization of the airway or the GIT. So it's hard to know if this is actually coming from the lungs, and it's significant. So for the diagnosis, you actually need 2 positive MAC sputum cultures, or 1 bronchoalveolar lavage culture positive for MAC, or AFB or granulomas or positive culture from a tissue specimen. But you also do need that with a compatible history and radiology findings. For disseminated MAC, you need to culture MAC from blood or another usually sterile site, bone marrow, spleen, or liver. Spleen, pretty tricky to get, I would imagine. In the patient we had, we did culture it from the peritonitic, the ascites, the acidic fluid, as well as blood. So, but apparently, even when you think you are getting a reliable specimen that you can count as positive, even if you get it in a lymph node or stool, if you send that off, or a GIT biopsy, that could just mean colonization or local disease. So you need culture from 2 organs to say that this is, or sites to call it positive. But in HIV patients, positive immunocompromised patients, blood is the preferred means of diagnosis. And it's helpful to take more than 1 sample. 1 culture can give up to 90% sensitivity and increase up to almost 100% once you've taken 2 back ticks looking for MAC. But just from our point of view in PEDS, I just thought I would mention some of the difficulties in PEDS patients when it comes to especially an positive AFB on our report. It's difficult to obtain representative sputum specimens. So a positive culture or seeing it on the sputum or gastric washing may just indicate colonization or contamination. I just thought I'd have a word about the isolated lymphadenitis. So like, for example, cervical lymphadenitis, apparently you're not always going to actually culture it. So they might fail to grow an organism, or sometimes, I must say, we send that, they go to theatre for it and someone hasn't ticked to please culture, so it's not requested. So you just know that they've aspirated and they didn't get TB, but we don't know what it was. Apparently, what is suggestive of MAC is granulomatous formation, but without the necrosis or caseation. But I do wonder if I've seen one or two of these patients before who've had year-long histories of a lymph node in the neck with no diagnosis ever, despite trying to send off either histology or an FNA. And they're not otherwise that ill, they're fine, but they've got this mass. And apparently it is self-limiting with time. So they might eventually actually go away and aren't that harmful to the patient. And just to be aware that the lymphadenitis can be part of the iris picture in HIV positive patients who start treatment. And another issue, I think, with making problems for ourselves in interpreting results is that we We don't see it that often nowadays because I think we start ART very young in the newborns if they're positive. But we used to see it in children. We started on antiretrovirals at 6 or 10 months, and they'd get a BCG adenitis or BCG iris. And if someone thinks, well, let me send that off, they send it to the lab. Obviously, they're going to see acid-fast bacilli, and there's this confusion as to whether to start treatment or not. And I think, again, luckily, someone I know once was told by someone at the clinic, no, the child now needs 6 months of TB treatment or something. And the child was growing well and was otherwise fine. So once we look for it, we see it, and then we think we need to treat it, but it is not always necessary. And I think often in an outpatient setting, sputum is sent. You think you better look for TB. So we often work up patients for TB because of an ongoing cough. I'm sure a lot of the time it's asthma, but we're too scared to miss TB. But often they're not even particularly unwell children. Cough is common in children, especially if they're younger and going to a creche, something like that, and they recover from a cough only to get another cough so that it would appear they've had a 3-month-long cough, and now you better look for TB, but they actually have had virus after virus. So they get investigated. And obviously we feel we must because of the high incidence in this country that we can't miss it. Sputum, as we've said, is unreliable. And often as outpatients, we only might get 1 or 2 gastric washings, which aren't always that helpful. And then they might also get sent for a chest x-ray that might say there's some lymphadenopathy. Again, that's not necessarily specific for TB. A viral infection could also do that. So it's quite difficult to know. And so what happens, I think, sometimes is then they get us a result back. They're called back. This patient looks well as anything, but now you're looking, and that cough is gone, or it went and another one came, but they look okay, and now you've got AFB on the report and you're not sure what to do. So the process that it should be, and the process that is followed, I think, by the lab is that, and as we should send a specimen. Usually sputum is sent, but if you have tissue, that's probably best, the most sensitive. And we request TB non-nucleic acid amplification test, which is the Gene Expert MTB RIF Ultra. We also tick microscopy, which is our acid-fast stain. And then we must always also ask for TB culture. Just by the way, I think that standard now is to use the liquid medium, which is in the labs called the midget, the mycobacterial growth indicator tubes. And that's what we know as Bactic bottles. It's apparently faster than the solid media. So we send our specimens off, tick the right boxes. And then if NTM are there, they will appear as AFB when they first look, but the sensitivity is low. But if they do see it, they will report that as AFB. But the nucleic acid test is specific for MTB complex, so it's going to be negative for NTM. So that combination of the positive AFB with a negative nucleic acid test would suggest the presence of non-tuberculous mycobacteria. So you might initially, you should treat with reserve, basically, unless you had a very good reason to suspect something like MAC. And then you have to await culture. The rapid growing mycobacteria can grow in as little as 10 days. Slow growers generally take longer than 2 weeks. And then once that grows, if that grows something, then they do a PCR and can do a 16S ribosomal RNA gene analysis for the species identification. But I stand to be corrected. I'm not sure this is always done if this was a specimen where it was considered a contaminant. But I also think that if you have any queries or would like to, if you think the lab must please persevere with identifying the organism, then speak to the lab. Susceptibility testing is then done especially for the rapid growers, and that's done using broth microdilution testing. Okay, so I'm certainly not going to go through this, but just to say again, the one that I've seen more of the NTMs is the MAC. And the treatment options, just to say they're not our standard TB treatment. 1 or 2 would overlap, but sometimes we just don't know, and we're really desperate with an advanced HIV who is sick. We don't actually know if we should be treating for TB, MAC, both, neither, and it's just quite a high pill burden. And yeah. So one lesson I think there is to be learned is to be careful what you ask for. I think don't just send a sputum on someone who's had a cough for a week, or, you know, someone who you don't really think has TB, because you're going to have to do something with that result. Because we see an AFB on sputum or gastric washing, now what? So is it TB? Is it MAC? Is it both? Is it neither? So review your clinical picture and take that into consideration. I feel it's always been extremely helpful to discuss with the TB lab and await further identification, make sure they've got your specimen, find out where they are with the processing, and yeah, they'll give us feedback. And also ask an ID specialist, a TB specialist, for advice before embarking on unnecessary or incorrect treatment, or before ignoring and delaying treatment. Probably send another specimen correctly collected, labeled, and if the patient is sick, send samples from every possible source. Obviously, sometimes a bone marrow is a little extreme. If we can, like with the MAC, bone marrow is apparently positive earlier in the course of the disease, but your blood cultures, your blood bactec will be good. So send a repeat one as well, and try and see if there are other fluid sites for samples. Thank you.
Cool. Thanks so much, Judy. Looking through the chat, there's a lot of good comments. Some quite entertaining ones about the carbofusion state, that I pronounce it that way. Apparently, it's been looked at by Stephen Gorsman. He says that in UK English it's carbofuchsine, and in US fuchsin as well. And then underneath it says "fuck like cook." So I'll leave it to you. But we've all learned something today. That's fantastic. So it's none of the above in terms of any of the thoughts I had in terms of how to pronounce it. Then Chitalu's Chandra's asking about how long does GeneXpert remain positive after completion of treatment?
I would be guessing, so I think someone else might know better. I'm going to say 3 to 6 months. I have no idea. I'm sorry.
So
no.
Before the Ultra came along, which is even more sensitive, so you think probably even longer, there were certainly reports, and I mean, again, this is not the majority of people, but a minority of people, up to 3 to 5 years, especially in the pulmonary cases where there's cavitation. So probably some dead bacilli sitting there. So it didn't regard it as treatment failure, but it's a big limitation of second episodes of TB. You know, in other words, if especially in cavitatory lung cases, I think it's very different if you saw AFB in a sample which should normally have been cleared of AFBs, but in lungs, I think it is a bit longer. Narcisa is saying, so I think this was in the context of the getting some sputum. You had that nice slide there for AFBs. It says, what's the rationale for step 1? Drink water before bed.
I only actually saw that as I was presenting now. I just copied and pasted the best picture, and now I saw, why on earth would you drink water before bed? Maybe so that you're well hydrated in the morning and can give a good specimen.
Maybe.
I really don't know. It must be filtered.
Lucille's got a good comment which is related to that, saying, you know, you ask about the filtered water. She's saying, obviously, don't use the tap water to rinse the mouth because they may have environmental mycobacteria in them. So, you know, we know MAC is in some of the water, and et cetera, et cetera. So that's a good reason not to have the filtered water. I'm not sure how often that's adhered to, but it's clearly good.
That's brilliant. I just thought, yeah, it's asking a lot of our patients, but okay, yeah.
Then Tani Dlamini Miti, who's running one of the bigger TB research organizations, said, may I suggest we rather say AFBs when looking for extrapulmonary TB in addition to GeneXpert, and when monitoring. Otherwise, we'll have people reverting to requesting AFB as the first diagnostic test, which we know is substandard. Yeah, so I'm sure, yeah, I know you were clear with your words, but obviously just to reiterate to everyone that it's definitely not the preferred screening test, right? We want to be using, or not even screening, but diagnostic test. We want to be using nucleic acid tests like GeneXpert or others, obviously instead of AFB. But obviously there's still a role for AFB in terms of monitoring, as was mentioned there. So you should still revert from AFB positive to negative if you were AFB positive at baseline, which obviously not everyone is. John Freen is making, so it's the Buruli ulcer, not Burundi ulcer, he's saying. In Australia, it's also called the Bairnsdale ulcer. So I think the Australians are still peeved at being I think they were the first to describe the ulcer, but didn't link it to the bug. I think if I remember the story correctly, so they still calling it the Bairnsdale ulcer. John can correct me if I'm wrong. And then Leon saying with BCG, the lab report comes back as MTB complex, which often causes confusion in the clinics. Clinicians should alert the lab they're suspecting BCG so that the TB lab can do further testing. So that's for the sort of BCG-osis, right, Judy? Oh, you muted, Judy.
Sorry, yes, no, I couldn't find it. Yes. So, but like I said, I think there has to be a very specific situation where you send that off, because I don't find that it's generally clinically helpful, to be honest. But maybe if you are going to, if you're worried about disseminated BCGosis and maybe from the other axilla, because the same side you've done your BCG, I think you're going to expect to find it. So I struggle to know when one should actually send that off, because I think we know what we're going to find. But yes, that would be in that situation. Specify what you're looking for.
Yeah, and we sometimes see it in adults too, especially in immunocompromised. You know, they can have it as well with, for example, if the BCG is used for the bladder cancer and things like that. So it can occasionally catch people out. And then there's questions about duration. So let's start with this one. So how long would you treat MAC isolated from other sites other than pulmonary?
I'm certainly not the expert, but and assuming the patient actually survives, I think it goes on 12 to 18 months. But I'm sure you use various criteria to actually see that they're clinically improved and their CD4 is, I don't know, above 50, above 100. But I'm not sure. Again, I stand to be corrected, but I've just heard 18 months.
That's right. So for, again, I can't talk for peds, but for adults, we would, so if it's disseminated MAC, say we'd usually do it for about 12 months, but obviously we're also assuming that you're getting culture conversion in that time. So if you were blood culture positive initially with MAC, then we'd want to see that you're doing well clinically and that your subsequent cultures are negative. It's the 12 months thing is really poor, low quality evidence. So it's likely that if you gave someone ARVs and they were doing really well and they cleared their cultures, you might be able to get away with less. But very few people have tried that, and I think people are scared to do it for, perhaps for good reason, given the lack of evidence. So the durations with all of these things, apart from TB, are quite low quality evidence, often just sort of best expert opinion. And I just see the same. Oh, so Nasisa's saying same duration in peds and same principles, so she's agreeing. And then a similar question about what's the treatment duration for Mycobacterium abscessus. So I think again there. So if you're dealing with pulmonary specimens, most guidelines would say 12 months after sputum conversion. Sometimes if it's not pulmonary, if it's like skin and that, it might be a bit less. You can probably get away with 6 months. But again, it's I think once you understand most of this is made up in a sense, there's sort of expert opinion and very low quality, case series evidence and things like that, that these durations are quite tricky in most of the mycobacterial diseases. Some of them have a little bit better evidence for it, but obviously TB is well described, but the other ones nowhere near. And then Narcisse is making the point that severe immune suppression takes longer to recover, like from MAC. Yeah. And then Michelle's asking, so perhaps answer from a peds perspective, Judy, then, so please confirm to me, she says, is it official guidance to submit 2 sputum and more specifically gastric washing samples? If so, any idea of whether and how often this is being done?
Do you mean 2 versus just 1? Sorry. Or is it
I think
official?
so, yes. I think that's the thrust of the question. Michelle, if I've got it wrong, just you can type in it or raise your hand.
I think it should be at least 2, if not 3.
And what you do for gastric washings is similarly also 2?
Yes. Yeah.
Okay, got it.
Ideally 3, but I know we often don't manage. Yeah, and if I think this is, I have questioned before, if we send more than 1 gastric washing on the same day, it isn't processed. But I think if there's a significant time between the 2 specimens, otherwise you can't. I think the assumption is that we've just split the specimen and that it's not going to yield much more by doing that. So the lab will not actually process that second one on that day at the same time. So sometimes we have to wait a day.
Okay.